So if you had like 3 extra players, like we could have scored like 7 or 11. Like I'm really excited for next year to have all these like new freshmen come in and just have like the numbers. Yeah. Because like some of the games we played this year, like, we should have won, but just didn't happen. Like next year we'll be able to like really compete and like actually like blow people out. Like EMU should have won, but I'm excited for next year. It'll be funny though if we like keep going until next, because I haven't done that and I'm so used to being done. Yeah. Like on one week, I'm like, oh yeah, it's so. But like that's a long time to like keep playing. We probably practice. Yeah, same. We like could be done. We practice. Let's not have any more games, but we're just gonna like have a fun practice and stuff. And on my own. You know when the exams might be?
I'm gonna try and get them done today. I caught up on all my grading on Blackboard for all 4 of my classes yesterday. And so then when I went to grade your exams, I was like, I'm not gonna be able to grade these accurately. And they're stuck in here. They're like blurred from staring at the screen. So yeah, my hope is I'll get them done and post your grades today. But if not, Wednesday.
Okay.
Yeah, usually I try to do them within a week, but I was behind on everything else, so. But yeah. Alrighty, well, I don't know, I mean, like, we don't even have that many people on Zoom, so I'm not really sure, everybody's just like partying already for Halloween. But I'm gonna go ahead and share screen. And we'll go ahead and get started. So today we're starting to talk about, I think, what's a lot of people's favorite topic in psychology, and that is different psychological disorders. And so I know that people do really like learning about these. A lot of us have had personal experience either with our own diagnoses or with someone in our family or our friends maybe struggling. And so I think that really resonates with people because of that as well. All right, move this out of the way. Go ahead and get these captions going just because they're so much easier to read. Okay. So one thing I'll say really quickly before we dive all the way in here is that what we even call this as a class has changed. And one of the things we're going to talk about is sort of like how do we decide what is a disorder and what's not? And so maybe I'll just talk about when we talk about, I have a slide of like all the different things that has been called it. So sometimes you'll hear this called abnormality, psychopathology, disorders, disordered. So what do we call this? And it has definitely changed over time, and certain words have become more or less stigmatized over time. The term that's usually more accepted now is psychopathology. So I think just 2 years ago, we changed the name of our course that focuses on disorders from abnormal psych to psychopathology. This just more fully recognizes that these are mental disorders people struggle with, they're diseases. They're not just the person being weird, right, or abnormal. And so that's what we've decided to go with. And, you know, terminology will continue to adjust. Sometimes you'll hear them called maladjustment or emotional disturbance or mental illness. You know, we used to just use words like unstable or madness or insanity. Crazy started as a slang word in the 1600s. And nuts was a slang word that started in the 1700s. So, you know, some of these terms have been around for quite some time. And like I said, the language will probably continue to adapt over time. But right now we're sticking with psychopathology because again, it accurately gets at the idea that this is a mental illness, right? This is something that people aren't choosing just to be quirky, right? This is something that afflicts people, and more we're finding that a lot of these diseases do have basis in brain pathology. So how common is abnormality? Way more common than we think, right? Which is again why like calling it abnormality is strange, right? So about 30% of adults, almost a third of adults, and 90% of kids and adolescents will experience some sort of serious psychological disturbance and need treatment. Now, this doesn't mean that this is a permanent disability for any of these folks. Therapy can be very effective, as can medication, but it does mean that big chunks of people that you know, or again, maybe yourselves, might be struggling with these serious. Are we all tickled together?
Yeah, I think it.
Oh, that's. There you go. The plastic was your enemy there. So the most common disorder that's diagnosed is depression. And this isn't just feeling like I feel a little down today, right? So major depressive disorder is a pretty debilitating disease. And it's pretty common. So lifetime prevalence is about 10 to 20% for women and about 5 to 12% for men. Now, one thing I'll say as we look at all these statistics is these are all probably underestimates because a lot of people suffer in silence and never choose to go get treatment and therefore never get diagnosed. And so we probably have many more people who aren't getting the help they need, who are struggling with mental health. Something like schizophrenia, more severe mental illness, is much less common, somewhere between 0.5% and 1.5% worldwide. And to take us back, of thinking about prevalence versus incidence. So prevalence is the number of cases that exist at any given time. So the number of cases that exist. So prevalence is essentially the percent of the population affected by this disorder at any given time. Incidence is the number of new cases within a certain time interval. The number of new cases. So prevalence is just how many people have it right now. Incidence is, in the past year, the past month, how many people have been diagnosed, essentially. So how do we define pathology, abnormality, right? No one can agree, but there are some commonalities. So Rosenhan and Seligman described it as maladaptiveness, unpredictability, suffering, irrationality, or maybe incomprehensibility, observer discomfort. Now that's a really interesting way to describe someone else's disorder, right? If the person watching them is uncomfortable by it, imagine if we tried to diagnose diabetes, right? It's a really weird criterion. Vividness and unconventionality, violation of moral and ideal standards. And now not every single person who is going to have a mental disorder is going to have all of these, particularly the last one. The last one we really only see, I would say, in a handful of mental illnesses. Things like psychopathy, which we call antisocial personality disorder, and things like pedophilia, pyromania, things along those lines. So in 1986, Levine came up with more succinct criteria with a helpful acronym to remember them by. So IMAD, problematic in its own way, let's fully admit. But the I stands for inefficiency. So this having a pathology gets in your way of being able to do things as efficiently as other people. It's going to feel harder. It's going to take longer. So inefficiency. Then the M is misery. This is a really common criteria for the vast majority of the diagnoses. Like in the criteria to diagnose the disorder, there's often something like interferes with work, social things along those lines, that it is gonna cause misery. A is alienation. Whether that is other people alienating you based on them not understanding what's going on with you, or the pathology itself causing you to alienate yourself. There are many different disorders that, like, you just don't feel like being around other people. So alienation. And then the D is disturbance to both yourself and to those around you. And then Comer came up with 4 Ds, and they have their own slide here. So deviance. And I think that this is an important one in cultural context. So what we decide as a pathology certainly is a lot about deviation from the norm, right? So being different, extreme, unusual, bizarre. So you're deviant from the current sociocultural norms. Explicit and implicit rules for proper conduct established by the society, right? We all know these, right? You're supposed to act certain ways, be certain ways. Sometimes it's law, sometimes it's just something you know, right? Like it's not cool to do X, Y, Z. And these come from that society's culture, its history, its values, its institutions, its habits, also skills, technology, arts, right? All of those things. And these will change, norms will change as the culture changes. So the picture I have on here is of Danica Patrick, who is now like just another race car driver. But when she first came out, it was a big deal. That a woman, oh my gosh, a woman can drive a car and she can drive it fast, right? I mean, it sounds so silly now, but like it was a big deal when she first was emerging. So if you violate legal norms, it's criminal. But if you violate these psychological function norms, then you have a pathology, right? And I think this is really important to keep in context, so that there are certain things that have been considered pathologies throughout history that no longer are. So for example, up until the 1970s, homosexuality was considered a mental illness. No longer, we fully acknowledge it's not. We have renounced the quote unquote conversion therapies that were supposed to treat homosexuality, but really just gave people PTSD. But up until the 70s, it would have been considered something diagnosable. We also have to take that person's circumstances into account. So for example, people who had PTSD or depression after 9/11, right? That was understandable. Doesn't mean we can't help them and get them treatment. It just means we have to take their circumstances into account. Distress is that, the symptoms they experience might be unpleasant and unsettling or upsetting. And this is not always necessary. So some people, for example, with schizophrenia or other psychotic disorders are perfectly content to coexist with their delusions and hallucinations. When people are in manic episodes, they might gleefully spend all their money. It doesn't necessarily mean they don't have a disorder. Dysfunction means that it interferes with daily functioning. It can be really difficult to live a normal life. A client that stands out for me that I saw on my residency was so severely depressed that she could only bring herself to shower about once a week because that felt overwhelming, right? Which, like, for the rest of us, we're like, what are you talking about? Showering? Like, you jump in, you jump out, you're good. But for her, like, that felt onerous. People can't live normal lives. They can't care for themselves. They can't work. They can't socialize. And then danger to self or others. Again, not necessary, but certainly present in some disorders. Sometimes people are careless, hostile, or confused. And in particular, again, people with antisocial personality disorder, those we call psychopaths, are the clear example of this, like they kind of don't care if they hurt other people. But there can be things that you do that are dangerous but not diagnosable or not seen as diagnosable, because they are not uncommon. So again, here's where culture comes back in. The example that we came up with in grad school is our grad school training clinic was just in our psychology building. So we saw a lot of folks like yourself, college students. And college students often engage in behaviors that if they were not in college would be diagnosable as a substance use disorder, binge drinking, things along those lines. But because that's normative in college, we wouldn't diagnose them, right? So we kind of like jokingly came up with like college drinking, not otherwise specified, right? Not something we'd actually document. But just sort of to remind ourselves that just because someone's in college doesn't mean we should rule out that they might actually be struggling with a substance abuse issue. You know, people who go to parties on weekends, probably fine. People that it starts to creep in and affect the rest of their lives, we need to be aware of that. The other end of the extreme, sort of the people who would fit all of these, but that we accept, are people that we might call like eccentrics. So these people are like, have marked individuality, they deviate from common behavior, might display odd or whimsical behavior. So think about a lot of artists, actors, right, things along those lines. Or, you know, the crazy cat lady example, like she's not hurting anybody, but people think she's different. In general, research shows that people who are considered eccentric don't suffer from mental disorders. And they have fewer emotional problems and fewer physical health problems than the general population. So I have a video, I'm not sure if we'll watch the whole thing, but I thought this was pretty interesting. This is Dr. Ali Mattu, who is a licensed psychologist who's also an influencer. And he is analyzing depictions of psychopathology in film.
Antisocial personality disorder includes both sociopaths and psychopaths. They have some things in common, but there are very distinct things. I'm Dr. Ali Mattu, clinical psychologist, and today we're going to be looking at mental illness in movies.
In New York, does it remind you?
That's manipulative. I don't want to talk about it.
Are they coming back? The aliens?
Maybe. Can you stop?
So that's kind of a pretty good example of trauma right there.
Does this subject make you edgy?
Yeah, a little bit. Can I just catch my breath for a second?
Now he's starting to feel some panic. He's been triggered.
To breathe into? Do you have...
This is a really good example of how everyday situations can trigger someone and the other person might not even know that they're triggering someone's trauma.
Do you want me to
Remember when I said to stop doing that? I'm swear to you, you're gonna freak me out.
I really love Marvel movies, and Iron Man 3 is one of my favorites because it's such a good representation of anxiety. Here we see Tony experiencing panic. Hyperventilation is a pretty core symptom of panic. We see Tony Stark avoiding a lot of situations that are difficult for him, and that's a big hallmark of anxiety. It's a good example of trauma because trauma happens when fundamental belief you have has been challenged in some way. He's always been able to engineer his way out of danger, and this is the first time he couldn't. In the movie, his anxiety just sort of seems to resolve itself, and we don't really see how it's resolved itself, but I like what they show us in terms of the examples of anxiety and trauma there. Okay, I haven't seen Split yet, but I really want to see it.
With regard to Jahamana's defeat and Muhammad of Ghor's conquest between 1192 and 1200, I would liken it to Muhammad's brazen ultimatum that
So this is looks like another dissociative identity disorder. It's kind of interesting idea is like vlogging as your different personalities to yourself.
Choke. I hate my insulin shots. No one else around here has to take them. What do I have to do? Diabetes.
So accurate representation, different tone of voice, different presentation, different way of talking, different way of sitting.
Huh? How do you explain I'm the only
And dissociative identity disorder is what used to be called multiple personality disorder.
one that needs these, you motherfucker?
okay, I have no idea what's about to happen, but it's kind of interesting. What's unusual about this example is his different personalities seem to be talking to each other. Some personalities can interact with each other, but to this level of communication and coordination, probably not. And dissociative identity disorder is also very controversial. Some people think it's a representation of schizophrenia, and that is a big myth. The confusion comes from the word schizophrenia. Schizophrenia means split mind, and that refers to the split between what's really happening and what someone's experiencing in their mind with hallucinations. He has kidnapped these other women. It's an M. Night Shyamalan film. In this kind of stuff, you suspend your disbelief a little bit more, but this is where a lot of people get ideas about mental illness. I don't think a lot of people take it too seriously, but it is perpetuating some myths. Yeah, I haven't seen Beautiful Mind in many years, but I remember really liking it. Oh my gosh. This is like really sad to watch now.
Charles was watching and he was okay.
So he's experiencing a visual hallucination. He's seeing something that isn't really there. And it's much more common to have auditory hallucinations, to hear things, but some people do experience visual hallucinations. A big part of schizophrenia is confusion and fear and not quite understanding what's happening, and I think we're seeing a good example of that.
Charles was watching.
So one of the things about schizophrenia is learning how to identify your symptoms and learning what is an hallucination and what's actually real. John Nash in this scene realizes that one of his hallucinations never ages. That could be an effective form of coping for him. I've heard other people say, if my dog is not reacting to something, then I know that's my illness. That's a pretty realistic way to cope with it. One of my only issues with A Beautiful Mind is at the end there is sort of this message that you can sort of outthink schizophrenia, and that isn't, it's not the most realistic. What's really great about A Beautiful Mind is it shows someone who has schizophrenia who is not violent, and that's a big stereotype about schizophrenia. Most people who have mental illness are not violent. They're much more likely to be the victims of violence than they are someone who might be violent themselves.
And that is super, super important because, particularly with mass shootings, we tend to blame it on mental illness, right? Oh, they must have been mentally ill. The vast majority of people with mental illness are not going to harm other people. And so psychologists really argue we should probably be looking at our culture instead of individual mental illness.
Sally Dibbs, Sally. 461-0192.
A lot of people who have autism do see visual patterns to a much higher degree than people who don't have autism.
461-0192.
But they also really struggle with social interaction.
You memorized the whole book?
No.
You start from the beginning?
Yeah.
How far did you get?
G.
I think Tom Cruise's character is a good representation of how hard it can be for people who don't have autism to understand it.
So I don't think they gave that clip enough context. What happens in this clip is that the main character who's in the foreground here has actually memorized the whole phone book up till G. And that's how he knows Sally Dibbs, their waitress's phone number.
Maple syrup is supposed to be on the table before the pancakes.
We haven't ordered yet, Ray.
Of course, when they bring the maple syrup after the pancakes.
So needing things to be a certain way and then getting really emotionally overwhelmed when they're not like that, that happens a lot with autism.
I know toothpicks, I'm definitely not gonna.
I like that representation. It does a good job of showing the differences in how someone who has autism versus someone who doesn't have autism, how they see the world, and also the challenges of working together and understanding each other. The only thing I don't like about this representation, it does show more of a narrow view of the functioning of someone who has autism. Now we know it's a spectrum, and people are all over on that spectrum. But that's more just representative of when this movie was made. Other than that, I think it shows those main features of autism, the focus on visual patterns, on logic, a little bit of rigidity, and difficulty with social interactions. It shows those really well. I haven't seen this in a long time, but I remember liking its representation. It's the middle of the night, so he's clearly having a hard time falling asleep, which sleep problems are a big part of bipolar disorder.
It's after 3 o'clock. What are you doing?
I looked in here, but this is all your shit up here.
And he's focused on something, trying to solve a problem. We call that goal-directed activity, which is much more common when people might be experiencing manic symptoms. This is also a great example of how bipolar can impact families.
Are you going to my study?
Feels to me like you want to hide.
He's a bit more irritable, more frustrated, more upset. That can also really happen when someone is more manic. Bipolar is all about moving fast or moving slow. We're definitely seeing that fast part right here. This is a really quick escalation of stuff, but this kind of sequence of events can happen with bipolar disorder when someone is manic. It wouldn't happen this quickly, but you know, it's a movie.
Let the whole neighborhood wake up. I don't.
That was pretty good. Very quick escalation. It wouldn't happen that quickly, but it does a good job of showing us the experience of being manic. We also see a lot of that emotional sensitivity, intensity of the emotions. One of the biggest triggers for bipolar disorder, if you're not sleeping as much as you used to, or if you have trouble falling asleep, it can have a huge impact on your mood. I love Sherlock.
I think from now on we'll downgrade you to casual acquaintance, no more than 3 planned social encounters a year, and always in John's presence. I have your contact details. I will be monitoring.
They're right about you. You're a bloody psychopath.
High-functioning sociopath. With your number.
That is such a good line. I love that, because that speaks to this difference between sociopaths and psychopaths. There is a difference in how we use those terms. Both categories, they might break rules or break the law. The difference with a sociopath is they can form connections with other people. Sherlock definitely has a relationship with Watson. He definitely cares about him, so he does have relationships. He doesn't just simply manipulate people. The thing that's a little bit less realistic is people who are sociopaths, they tend to be more reactive, more impulsive, more emotional than psychopaths who are more cold-blooded, more tempered, more calculating. This Sherlock, I think he's a bit more on the autism spectrum. He sees patterns, doesn't interact with people the same way that other people do. He's not impulsive like we would think of many sociopaths. I remember being so blown.
So I'm gonna stop there, but you know, you can definitely watch more of this later if you want. I think things like this, and there are multiple things like this, like therapist or psychiatrist reacts to pathology in movies. Highly recommend those because they really break down and tell you what's accurate and what's not. And then I wanted to share these with you. These are some links to good, accurate content about mental illness. So the first is Ali Matu, who we were just watching. That's his YouTube channel, The Psych Show. One of my faves is Cinema Therapy. So it's a guy who's a movie director and his best friend who's a therapist, and they watch movies together and analyze how accurate things are. Sometimes they just break down relationships. And then this last link is a playlist of Crash Course Psychology. So consuming this type of content will give you accurate views of mental illness that oftentimes, unfortunately, movies and film aren't always that good at. Give you the worst example, the movie Me, Myself, and Irene claims that Jim Carrey's character has paranoid schizophrenia when in fact he has dissociative identity disorder. Right, so people don't always do their research. Right, so the first type of disorders we're going to talk about are the mood disorders, and we're going to talk about those because they are the most commonly diagnosed. And they are also the disorders about which we know the most in terms of like the pathology itself and how to treat it. Interestingly, so I should back up 5 steps and say the manual we use to diagnose people is called the DSM. So that's the Diagnostic and Statistical Manual of Mental Disorders. And they're forever updating it to get the most accurate information. And yeah.
Is there a difference between that and DSM-5?
Yeah, good question. Yep, exactly what I was going into. So you're reading my mind. Yeah, so the DSM-5 is just the most recent edition.
Okay.
Yep. And so, you know, when it first came out, it was just the DSM. It's been through many iterations. The most recent one before the DSM-5 was the DSM-4 TR, which stood for text revision. Apparently, they're going to put out a DSM-5 TR in the next few years. And those just mean we haven't really changed the diagnoses, but we realize some of the information that we have in there is inaccurate and we want to update it. So in that last edition, the DSM-5 TR, everything, bipolar, depression, they were all shoved into one category called the mood disorders. But in the DSM-5, those have been separated out. They recognize they're distinct enough to each be in their own category. So there's a category for depressive disorders, and there's a category for bipolar and related disorders. So fully recognizing these are distinct enough to have their own categorization. Quick editorialization about the DSM. So the DSM is put out by the American Psychiatric Association, not the American Psychological Association. So it's put up by MDs, psychiatrists. And for that reason, it's sometimes controversial because psychiatrists tend to look at things through the medical model more than psychologists, who tend to look at things through what we call the biopsychosocial model, where we're looking at sort of all aspects of things together. There's also been concern that because, how do I put this in a polite way? Drug companies could have a lot of influence because they have a lot of money, and good psychiatrists, this won't happen. But sometimes we've seen things come into the DSM just because there's a medication for it. So for example, restless leg syndrome's in the DSM. In my opinion, there's nothing mental about that. Like it's a physiological disorder.
Yeah, like I'll keep that after like during the jogging game and like my legs just like I won't be able to sleep if they don't like.
Exactly.
It's
Yeah.
like
I mean, maybe there's a mental component I don't know about, but my understanding is it's purely physiological, right? Yeah, it's a little strange. So for that reason, some psychologists are skeptical. That being said, if you want to bill insurance, your patient better have a DSM diagnosis. So as of right now, we are kind of stuck with it, and psychologists have been trying to be part of the conversations. And often there are now a few psychologists on every disorders committee. All right, so depression and all the mood disorders, depression and bipolar disorders, are marked by what are called mood episodes. So a depressive episode, major depressive episode, is where you have at least 5 of these symptoms, and one of them has to be one of the first 2. So depression is a low, sad state, and life seems dark and its challenges overwhelming. So people experience depressed mood most of the day, nearly every day. And really quick side note, in kids in particular, and sometimes in adolescents, kids don't have the words to say I'm depressed, right? And sometimes they don't even have the words to like fully articulate when they're feeling sad. Like, just give you, again, my daughter's 4, so not always that accurate considering what older kids would do. But if I'm like, oh, are you feeling sleepy? She goes, no, I'm feeling happy, right? And I think it's because she thinks if we think she's sleepy, we're gonna make her nap, and she hates napping. But so, like, irritability is what we might see in kids and teens instead. So you need to either have that one and or number 2, which is diminished interest or pleasure in all or almost all activities, most of the day, nearly every day. Term you don't have to know, this is called anhedonia. And this is one of the hallmarks of depression. And as you can imagine, it sort of perpetuates depression, because if you don't feel like doing things you usually enjoy, you don't do those things, so you don't experience joy. And so then you are further depressed. So you need to have at least one of those. To be perfectly honest, and granted, these were people who were coming to therapy, so they had severe depressive episodes. But the vast majority of people I saw with depression had both. And actually had a lot of these symptoms, way more than 5. So then decrease or increase in appetite. It can result in weight loss or weight gain. And in kids, it can be a failure to make expected weight gain. And then sleep disturbance, and this can be both directions. It can either be insomnia, where you can't sleep, or what we call hypersomnia, where you just sleep all the time and yet you're still tired. So I knew someone in college who thought they had mono, because mono went around a lot when I was in college, and like went to their doctor, tested negative, but they're like, I'm sleeping all the time and then I'm tired. And their doctor was like, have you considered you're depressed? Right? And so like, we need to be able to rule those things out. It can look like physical illnesses. Psychomotor agitation or retardation every day. So retardation here is not in the way we use it as a slur now. This is like we use retard in music. It means to slow down. Typically in depression, you're gonna see the slowing down. I never saw someone who was depressed with the agitation, and I saw clients for 5 years. Doesn't mean it can't happen, just means it's more rare. Typically people who are depressed move more slowly, talk more slowly, and it's like everything just sort of feels heavy to them. And that goes into the next symptom of fatigue or loss of energy nearly every day, and feelings of worthlessness or excessive or inappropriate guilt. And this is really interesting, because the way you ask about this on the structured interview for depression is you ask, how have you been feeling about yourself? And it's surprising, and there's no other prompt, that's it. And it surprised me how many people spontaneously said worthless, which is really sad, but also like shows you how accurate these criteria are. Diminished ability to think or concentrate, or indecisiveness. This one's really important. People don't realize this part of depression. And this can almost feel like ADHD or a learning disability. So when I was doing neuropsychological assessments for learning disabilities and ADHD, when I was in grad school, I don't know how, but I got all the people who, it was like they either had depression or anxiety, but it was manifesting like this. And you can still get accommodations and you can still be helped with that. But it was really interesting how many people said like, oh, I must have ADHD because I just blank out when I go to take a test. And it's like, no, actually you have test anxiety, or actually you're depressed. And then there's recurrent thoughts of death, suicidal ideation, or suicide attempt or specific plan. And so again, this is the most severe symptom. This is not consistent across all people with depression, but obviously if someone endorses this symptom, we take it very seriously. Okay, and so then mania is the opposite of depression. We saw that clip of Bradley Cooper in a manic episode, kind of rushing around, trying to find his wedding tape, right? And so it's a state of breathless, either irritation or euphoria or frenzied energy. And during this, people may have the exaggerated belief that the world is theirs for the taking. So a manic episode consists of a distinct period of abnormally and persistently elevated, expansive, and or irritable mood, and also increased goal-directed activity or energy. And technically, to be diagnosed with a manic episode, you need to have these symptoms for at least a week, but there was a new change in DSM-5, and it basically said, if these symptoms are severe enough where you need to be inpatient hospitalized, it doesn't matter how long they've been going on, you were having a manic episode. Before you were like, be hospitalized and they had to wait like 4 more days or whatever. Now you can just diagnose it. And then you need 3 or more of this list. So grandiosity, inflated self-esteem, feeling like you don't need to sleep as much, more talkative than usual, and or like feeling pressure to just keep talking and just get all your words out and just keep going. Flight of ideas or the subjective experience of your thoughts just racing. Distractibility, can't really focus on one thing. An increase in goal-directed activity. Again, you saw Dr. Matu talking about that. Sometimes this is good. Sometimes people channel this into their work and they're super productive. Other times it can end up problematic. Can be sexually. And then you're engaging in potentially dangerous behaviors by not taking the proper steps to protect yourself and others. And psychomotor agitation is much more common here than in depression. And then excessive involvement in activities that have potential for painful consequences. So in addition to those sexual indiscretions I just described, could also be buying sprees. People will just spend all of their money. Making foolish business investments. And then even more dangerous things. So, getting yourself intoxicated, whether it be on drugs or alcohol, and then driving, right? Because again, you kind of feel like I'm on top of the world, nothing can hurt me, of this grandiosity. There's also what's called a hypomanic episode. And so this is a distinct period that isn't as long and isn't as severe as a manic episode. Symptoms are essentially identical, but as you can see here at the bottom, it requires that the change be observable by others. So it's not just like someone having a good day, right? We don't want to over-pathologize people. And that it's not severe enough to cause marked impairment or to cause you to be hospitalized. If either of those things are true, it's upgraded to a full manic episode. But the reason hypomanic episodes exist is because some people never get to the full-blown manic episodes, but these hypomanic episodes are still part of their mood cycling. One thing I should also say about mood cycling is that here's another example where movies are a little extreme. A rapid cycling person with like a bipolar disorder has several episodes a year. Movies tend to just play it as like it's during the same day or like over the course of a week you bounce up and down. Not actually the case. Because again, if you look at this, you've got to have like, even for a hypomanic episode, it's got to last at least 4 days, right? Depressive episodes, we usually put at 2 weeks. So you can't just cycle in a day, right, and meet criteria. So these are the different types of mood disorders. Some major depressive disorder. Some people will call this unipolar depression. But, the actual technical term is major depressive disorder or major depression. And this is what we commonly think of when we think of someone who has depression, diagnosable. And then there is persistent depressive disorder. This used to be called dysthymia. And this is a more long-lasting, less severe depression. People, to get this diagnosis, you have to have had the symptoms for at least 2 years. So this is like a long part of your life where you're just feeling bleh. Bipolar disorders, once upon a time, were known as manic depressive disorders. And some people still call them that. Bipolar 1 is the classic bipolar disorder we think of, where you have full manic episodes, full depressive episodes. Bipolar 2 is hypomanic episodes and depressive episodes. So you've never had a full manic episode even if you've never had a depressive episode, if you have a full manic episode, you're diagnosed with bipolar. Because we've never seen manic episodes without depressive episodes later. And then there's another disorder called cyclothymic disorder, which you have hypomanic episodes, but then like when you go into your depression, it would like never meet criteria for a depressive episode. So it's a more like persistent depressive disorder with some hypomanic episodes. And this chart is a little helpful to break that down. So if your depressive episode is moderate to severe and you don't have any manic episodes, you have major depressive disorder. If it's chronic and milder, no manic episodes, you have persistent depressive disorder. With manic episodes, bipolar 1, with hypomanic episodes, bipolar 2. And then this chronic milder depression with hypomanic episodes, cyclothymia. And then this is a great video I found of someone portraying what it's like to have depression.
Depression creeps upon you quietly. At the very beginning, you struggle with the little things, but you usually choose to ignore them. It's like a headache. You'll tell yourself it's temporary and it'll pass. It's just another bad day. But it's not. You're stuck in this state of mind. You get used to putting on a social mask and you continue to live among other people because that's what you have to do. That's what others do. However, the problem does not go away. You struggle to put on a play every day and it starts to cost you more and more. That is where you fall even deeper, and that's when you slowly start to back away from friends and family, sometimes completely shutting them out. All satisfaction is gone. The little things that used to bring you joy are now worthless. Even the simplest tasks become painful, and that is why you lack motivation now. Why would you keep on trying if nothing makes you happy anyway? All of this makes you feel even worse and you get caught up in a vicious circle. Suddenly you find yourself living in slow motion. Days become indistinguishable, just white noise, just heaviness filling your mind and spilling over your body. You feel as though you will never be happy again. You continue to back away and destroy relationships. You're ashamed for everything you've done and everything you haven't. There is a part of you that wants to make things right. A sudden positive upsurge makes you want to go out and meet people, but it's all very short-lived because you know it won't work anyway. Things that make your friends excited leave you indifferent, and you become aware of the huge gap that lies between you and other. Failure is not an option, so in the end you choose to be alone in your comfort zone where no one asks any questions. The low self-esteem and the lack of purpose become unbearable. You finally realize you can't go on that way, and two things can happen. You either decide to get some help, or you might attempt a suicide.
And one thing I'll say about suicide is a lot of people assume only people with mental illness choose to die by suicide. It's certainly not the case. There's a large percentage of people who die by suicide who don't have anything diagnosable. But certainly with depression, it's unfortunately fairly common. So I thought that was even like the pace of that was a really good depiction of what it feels like to live with depression. So just a couple more quick things before we go in. About 1 in 10 people in the US at any given time is suffering from a mood disorder, and depression is the most common. There's a lifetime prevalence of 16.1%. It's lower for men, about 12%. Higher for women, about up to a quarter, 25% of women will experience diagnosable depression at some point in their life. In contrast, bipolar disorder, much more rare, lifetime prevalence about 1.3%. And so major depressive disorder is where you've had at least one major depressive episode and you've never had a manic or hypomanic episode. And then, as I mentioned previously, the study of significant distress or impairment is a vital key to the vast majority of the diagnoses in the DSM. Will include something like this. The only time this isn't included is typically when that disorder doesn't disturb the person, but might disturb other people. So unfortunately, things like pedophilia, people who are pedophiles, unfortunately, don't ever think they're doing anything wrong, but clearly it's harming other people. All right, we'll stop there for today and we'll pick up with persistent depressive disorder on Wednesday.